to our next presentation by Dr. Dhanashree. So like Dr. Jain said, that like not all SRG need to be removed. The ones which are running across the macula and not allowing the macula to settle down would have to be removed either through peripheral retinotomy, or in rare situations you would have to do a 360-degree retinotomy or a temporal retinectomy, fold over the retina and then remove it. We'll go on to the next presentation by Dr. Dhanashree, which will be tips for prevention of PVR. Dr. Dhanashree.
Good afternoon, and thank you for the opportunity. So this is like a revision talk because some of the discussion has already been done in the previous talk. And you know, the PVR is very important because you see there are 3 talks dedicated to the PVR in this session itself. And nearly 80% of the recurrences or surgical failure is because of PVR. It can range from simple, few membranes, or it could be just a total, closed funnel. And this is actually a case which has been abandoned because of PVR. So the primary prevention of PVR begins with the treating of all the lesions such as horseshoe tears or lattices or symptomatic lattices or holes or areas of subretinal fluid, because then there will be no RD and nor there will be any PVR. Also, primary prevention begins with prompt repair of primary retinal detachment, which will prevent PVR. Important things to note is that you should use less cryopexy, because that is also supposed to cause more PVR, and also hemostasis should be done well to prevent PVR. But secondary prevention of PVR is more important, and that includes 2 things. One is the surgical measures, and second is the pharmacotherapy. So surgical measures is what we have already been discussing. So it begins with planning of sclerotomies and placement of infusion cannula. Sometimes with PVR the retina can be very anteriorly pulled, and it might be possible that the infusion cannula might be subretinal, like how you can see in this video. And if that is the case, then you can change the cannula temporarily. Make sure that your infusion port is clear of the retina, and then reinsert the cannula and start the infusion. But always make sure that the cannula is seen before you start the surgery. This is a situation where the entire 180 degree inferiorly there is a wound, and the retina and vitreous was incarcerated in the wound. So we have not given any sclerotomy in the inferior part, and all the 3 sclerotomies are in the superior part, and the infusion actually I have fixed at 12 o'clock. And so this prevented any retinal tear or injury which can occur right at the beginning of the surgery, which would of course make your surgery much more difficult. And in very extreme cases where you cannot put the cannula, here you can see the retina is in the pupillary area, and here I have placed one AC maintainer. So such things also can be done. The second tip is complete removal of cortical vitreous. It is of paramount importance to remove entire vitreous, including the vitreous base as well as the posterior hyaloid face, for your success of the surgery and to prevent PVR. Meticulous removal of membrane has also been stressed by Dr. Pramod Bhende. So all the membranes, whether they are immature, mature, small, large, all membranes need to be removed, and you need to spend enough time in locating the membranes and removing. So each fold of the retina and each crevice needs to be scratched to see if there is any membrane, and all visible and sometimes difficult to see membranes also need to be removed. If after removal of the membranes also you see the retina is crumpled, then there can be subretinal membranes, and subretinal membranes also need to be removed, especially those which will prevent the retina from getting attached. So here you see the retina was completely crumpled because of this large band of the subretinal tissue, and once that is removed, then the retina can settle very well. So the third tip is the role of liquid perfluorocarbon. So this is very important because the perfluorocarbon can help you work anteriorly when the posterior retina, bullous posterior retina can be settled, and it is can be supported by the PFCL while you work anteriorly and remove all the membranes. However, you have to make sure that it can also open up the closed funnel. However, you have to be careful not to inject the LPFC so that it can roll over the edge. So just short of the edge of the break, you should fill the LPFC only up to that level. This stage procedure has been described, and Dr. Naresh Babu here is a strong proponent of the stage vitrectomy, where in the first stage you do vitrectomy and leave the vitreous cavity filled with PFCL. The advantage is that no prone position is needed, and in the second stage, which is generally done 5 to 7 days later, the PFCL is removed and it is replaced with silicone oil. And so some surgeons, including Dr. Naresh Babu, have reported high success rate and low rates of PVR and recurrence of RD with this kind of staged procedure. Also, there was a mention of heavy silicone oil or Densiron, which can also be used to prevent PVR, especially for inferior retinal detachment or one-eyed patients or in patients who have had multiple failed surgeries previously. Role of encircling band is again very important. We know that the encircling band supports the vitreous base and also the areas of traction. So if you have areas of traction, especially inferior area, which is a very, very high risk for developing PVR and recurrence, then it is a good idea to either support it either with an encircling band or a segmental buckle itself. So this will highly increase your chances of reattachment of the retina. Next is the take care of the anterior retinal tissue. So this is what happens is that when you do the retinotomy, you will see that the anterior retina is unsupported and unlasered, and this area gets contracted and leads to further recurrence. So it is very important that you take care of that anterior tissue and do laser, proper laser to this. Either you can resect it completely or you can do laser and make sure that it does not cause any problem. Adequate retinectomy again has been stressed. So the retinectomy has to go beyond the visible area of contraction. ILM peeling has been again advocated as a instrument to produce PVR. However, this meta-analysis which was done, it showed that the ILM peeling can prevent ERM and it can reduce the recurrence rate, but there was no added visual benefit. It may have a role in early PVR, but there is no role in advanced PVR. And pharmacotherapy, again, is very important. We know that there are some pro-inflammatory cytokines such as platelet-derived growth factor, TNF, TGF, and calcium-independent phospholipase. So these are seen to be involved in signaling and proliferation of PVR. And role of steroids, all of us use steroid very profusely, intraoperatively, preoperatively, as well as postoperatively. And this study by Dr. Tarun Sharma showed that preoperatively there is a role of steroids in vitrectomy in prevention of PVR, especially in cases where there was also choroidal detachment. This study evaluated the role of triamcinolone intraoperatively, and they said that there was significant difference observed, but there is a possibility that the triamcinolone can cause toxicity, and they actually did not recommend use of triamcinolone intraoperatively. Antimetabolites for prevention of PVR, as we just discussed, have been evaluated for last couple of years. 5-fluorouracil and daunorubicin have displayed mixed results, and also there was systemic toxicity to do these. Methotrexate is a promising agent and several people are using it, including Dr. Naresh Babu. So as he mentioned, 400 microgram injection to be given intraoperatively, and then it has to be repeated weekly to reduce the PVR. But again, you have to take into account the chances of systemic and local toxicity, and associated recurrent detachment can still occur in high-risk patients. So the take-home message is prophylactically treat the lattices, horseshoe tears, and repair retinal detachment promptly. Plan the sclerotomies properly and the infusion cannula in the appropriate area. Remove all preretinal as well as subretinal membranes. Use PFCL to stabilize posterior retina. Can use encircling band to support the peripheral retina. Role of ILM peeling remains debatable. Preoperative steroids can help prevent recurrence, and methotrexate shows promise in PVR prevention. Thank you.
Thank you, Dr. Dhanashree. Anybody in the panel uses any other agents?
Mahesh, I have 2-3 points which I want to ask the panel also. And regarding prevention of PVR, especially anterior PVR, the most important thing is anterior shaving of the vitreous. If you don't shave the anterior vitreous, that's the scaffold where the secondary membrane, especially the anterior loop retraction, forms, and that's the most difficult to treat. See, an ERM, even if it forms at a posterior pole, I'm not so bothered. I will be able to treat it easily. But if the patient develops anterior retraction, that is very difficult to treat. So if you do a good shaving of the vitreous, especially the inferior vitreous, you can prevent that from happening. So that is one. Second, of course, you mentioned about doing the laser, and especially any doubtful areas. I would actually prefer to do laser from the ora up to the posterior vitreous base in that inferior area. That prevents the main objective is actually to prevent an anterior loop traction, an anterior PVR. Once you do that, the rest of the retinal detachments are easy, and the membranes also, when they form again, are easy to handle. So that's one thing. The second thing is about, which you showed also, about ILM peeling. Just for those where, when you went for surgery, if the vitreous was hazy, That's actually active PVR with a lot of inflammatory material. In those patients, one can consider doing ILM peeling at the posterior pole. That can prevent the recurrence of posterior PVR. And last point, that's a comment, I want to ask this from the panel also. You talked about treating symptomatic lattices. My question is, what about lattices which are posterior to the equator, lattices which are perivascular, and lattices which are radial, which nobody talks about? Would you like to treat them even if they are not symptomatic?
So in high-risk situations, you can, like supposing you have a very high myope, or you have patients such as sticklers who have inherently higher risk of developing RD. In these situations, you can treat lattices which are not the typical lattices which you see. Definitely you can treat, but in a non-high-risk situation, you can prefer to observe till the patient develops symptoms and till you think that that is the time to treat. You can observe them manually.
Anyone from the panel?
And the problem is, if answering this question will take us to the next tea break, so I will defer this discussion for later. I'll have Dr. Anand start. Yes, Manish, you have a quick comment?
Actually, a question for the panel. Is it that recurrences under gas, do they have more severe rates as compared to the recurrences under oil?
The risk of hypotonia and anterior loop traction is a little bit more with gas is what my perception is, but then like PVR, because the globe is formed with oil. In contrast, here the access of the inflammatory mediators is all through the vitreous cavity, so it seems to have a little bit more anterior loop traction. Yeah,
I think it's probably more delayed because you will go in much later rather than in anything else. So because there's a delay, it probably becomes more severe also.